Welcome to the Healthy Living Series, a series of talks brought to you by the University of Alaska's Summer Sessions and Lifelong Learning in partnership with Foundation Health Partners. My name is Joan Braddock, and I will be your host for this summer series. The Healthy Living Series, in its 8th season, has been a lecture series held in person in past summers. The COVID-19 pandemic and social distancing guidelines required that we rethink the format for the series this summer. We are delighted that KUAC has agreed to support the new format for this series as a weekly TV broadcast. We are also grateful to our speakers who were willing to be incredibly flexible in adjusting to this new format and appreciate the time they are donating to help us all live a healthier life. Before I introduce tonight's speaker, I want to let you know that you will be able to view the talks online after they are aired by going to the UAF Summer Sessions' website at uaf.edu/summer/events. I am delighted now to introduce our speaker this evening, Dr. J. Timothy Foote. Dr. Foote started at Tanana Valley Clinic as a pediatric resident in 1982. 37 years later, he is proud to say that he has taken care of 2 generations of Fairbanks' most precious people. In 1997, Dr. Foote began his training and studies into the field of allergy and asthma. He is board certified as a scientific member of the American College of Allergy, Asthma, and Immunology, with a special interest in sublingual immunotherapy for birch, food allergy, and the allergic component to asthma. Since 2016, he has focused his practice on allergy and asthma full-time. I will add that this spring, Dr. Foote has been particularly busy with birch allergies due to our world record levels of birch pollen in May. We are delighted tonight to have Dr. Foote here for his presentation, Penicillin Allergy, Not a Life Sentence.
Hi, this is Tim Foote. I'm the allergist at Tanana Valley Clinic. I am here in the clinic in our lecture hall. That's why I'm wearing a mask. I am speaking before an empty lecture hall, which is a little bit different. I somewhat feel like I'm singing in the shower or practicing my lecture in the car, which I tend to do from time to time. So it's a little bit strange, but I think that we're all used to strange times right now. I was asked by the Healthy Living series to talk about penicillin allergy, which is an interest of mine, and it's a timely topic in the medical community. And I've titled it Not a Life Sentence. And so it's obvious where I'm going to go with this lecture, and I think that probably a lot of you who are watching this lecture have a history of penicillin allergy, and I'm here to tell you that for most of you it's probably no longer true, and that would be the main gist of the lecture. So through the years practicing medicine, we were always taught that a penicillin allergy is permanent and it's no predicting how bad it could be, but it could be fatal. And we tended to shy away from questioning that issue. And it was pretty easy for a physician to have several choices in terms of antibiotics. And if there's a history of penicillin allergy, just choose another antibiotic. Usually had 2 or 3 that you could choose from depending on availability and cost, safety issues, and as a physician, your own personal experience with that antibiotic, and then what the literature said. But as time has gone on, it's shown that that's not the best practice, and it's not the healthiest practice for individual patients and for society as a whole. What you're seeing here is back to organic chemistry class. This is the biochemical configuration of penicillin. And to me, it always looked like a house and a garage attached to it. And that's the way I had to always memorize it. And I will just tell you that organic chemistry, for those that have taken it, it's probably the most forgettable class in college. You had to memorize a whole bunch of boxes and a string of carbons attached to hydrogen ions and all of this. And any mnemonic or way that you could remember it was always welcome. So the house and the garage was what this looks like. I don't know if you can see it or not, but I initially had titled my talk Penicillin Allergy, the Story of the House and the Garage, but my wife was the one who advised me that nobody's going to want to listen to a lecture about that when they don't know what it means. And she was the one who came up with the more apt title. But there is a beta-lactam ring attached to a thiazolidine ring, and then there's side chains. And the side chains are what determine the different types of penicillin. So there's penicillin, there's dicocillin, there's nafcillin, oxacillin, cloxacillin, ampicillin, amoxicillin, carbenicillin, ticarcillin, piperacillin. There's even probably gorillacillin, I don't know. But there's a lot of cillins. And they all can have unique allergic properties, but the one that is most important is penicillin. Here's an example of the different sidechain variations that determine what's penicillin versus ampicillin or amoxicillin. And I'll spare you any further details about that. So it's quite common to have a history of penicillin allergy. Fully 10% of the United States has a history somewhere on their medical chart of penicillin allergy. 15% of hospitalized patients have a history of penicillin allergy. It's true no more than between 1 and 4 out of 10,000, it's true no more than about 1 out of 200,000 people. So that exemplifies how many people no longer have the allergy. Penicillin allergy can occur, and it should be respected. It can cause anaphylaxis, and the incidence is about 1 to 4 per 10,000 penicillin administrations. And tragically, there are up to 1,000 fatalities from penicillin allergy in the United States per year. And the majority of drug allergy reactions come from penicillin allergy. So it can happen and it can be dangerous. Now the good news is that after 5 years after a reaction, a good half of all people are no longer allergic. After 10 years, 75%, 85% of people are no longer allergic. So it's not the type of allergy like an immunization. You get immunized to shingles, you don't have to worry about it for years to come. There is a half-life to this allergy. And I think that's a major point that would make people perhaps more motivated to try to get this evaluated and get it off their record. So why is this important? Well, there's a movement in medicine to be aggressive about getting this off people's charts. This comes from the American Board of Internal Medicine, it comes from the CDC, it's come from the American Academy of Pediatrics. Most major disciplines and specialties, subspecialties, has made statements saying, hey, this needs to be questioned. And they've found implications clinically in their patients. If you have a history of penicillin allergy and you have surgery, there's a 50% increased risk of a surgical infection if you use an alternative antibiotic. In pregnant women, if you have a history of penicillin allergy, there's an increased risk of C-section rate. In general, there's more inpatient complications from adverse effects from other antibiotics. And there's a few that I want to mention specifically. I don't know how many people have had diarrhea after an antibiotic, but it's fairly common. For a good number of those people, it's from an overgrowth of a bacteria that's called Clostridium difficile. And it's the twin brother of gangrene, truthfully. And this is a common side effect when you have, or this is a common cause of diarrhea from antibiotics. And what happens is if you use a strong antibiotic, it wipes out your the good and bad bacteria in your gut, and some of the more bad bacteria can overgrow unopposed. It upsets the balance of the gut flora. Clostridium difficile, if it's that one, and this can be transmitted in hospitals at times, can actually create a membrane that lines the colon. And if you did a pathology of it, it just lines the entire colon all the way around and causes severe diarrhea. And it will keep going until you treat it. It can be very severe. So it causes a membrane, and they call that pseudomembranous colitis is the name of that. Another potential side effect is something called MRSA. You may have heard of MRSA, methicillin-resistant Staph aureus. And this is a type of, a lot of people get like cellulitis or a soft tissue infection from a cut or a wound or an insect sting. And there's a type of Staph aureus, and that's a normal inhabitant of the skin that does not respond to the typical antibiotic that has historically killed it, which is methicillin. And so it can be more aggressive. Again, it can be common in hospitals. And so there's been increased risk of that problem with alternative antibiotics because you're wiping out good antibiotics. There's an increased risk of another type of diarrhea called vancomycin-resistant enterocolitis. So there is an impact on the gut flora. Some of the antibiotics, I will just tell you, can reverse your gut flora or alter it for years and possibly for a lifetime. And so it's important to use the most selective, the simplest antibiotic possible, which is our fallback, penicillin. People who are prone to urinary tract infections, 20% of women who have a urinary tract infection will develop a resistant organism. Bacteria are built to survive and to adapt. In the urinary tract, they can develop a resistance to the antibiotic that you're treating with. Less likely to happen with penicillin. If you choose an alternative to penicillin, the average increased cost is about $400 per prescription. So all of these are good arguments to try to get this off of your chart. Another group of people that we're interested in Fairbanks are pregnant women who have a positive bacterial screen for a bacteria called Group B strep. Now, Group B strep, fairly common with women, and we always screen for it right around 36 weeks because what we don't want to happen is for that bacteria to infect the baby just prior to delivery or as the baby's delivered because they have very poor defense against that infection. And it can be a very dangerous infection for the baby. So our obstetricians are very aggressive about looking for it and treating it in the mother. If you're allergic to penicillin and you have to have an alternative antibiotic, it doesn't cross into the placenta as readily as penicillin does. And so penicillin works better. It's safer. There's a 50% increased risk of surgical infection with the history of penicillin allergy. More C-sections happen. Penicillin, again, is more cost-effective. there were two major groups that studied how to approach this problem. One was in it was Cleveland Clinic, and the other was Kaiser down in Santa Barbara. And so we looked at both of those groups of people and decided that this was something we wanted to pursue and help our population with. And with the support of the obstetricians in Fairbanks, we went after this. And I ended up contacting the doctor that did the study in Cleveland Clinic, and he helped me devise a method of approaching this for pregnant women. And we have tested a number of women with that history. So what can penicillin do to you if you're allergic? Well, what you see there is what we would show the medical students. It's the different types of ways that your body can hurt yourself. And there's several different ways. The first type, that type 1, is your classic allergic reaction. And it can cause, penicillin, if you are allergic, can cause hives. It can also cause anaphylaxis, which means that there are multiple systems involved. For example, any combination of itchy, watery eyes and nose, sneezing, swollen tongue or lips, swollen throat, difficulty breathing, coughing, wheezing, chest constriction like asthma symptoms. It can cause vomiting, abdominal pain, diarrhea, so GI symptoms. These are all symptoms of anaphylaxis. It can make your blood pressure drop. You become dizzy or even lose consciousness. And then the other symptom, which is one of the more interesting one, is a sense of impending doom. So even before you have an anaphylactic reaction, you can think, you have the strong sense that something's wrong. I'm not sure what that is. So sense of impending doom is another sign of anaphylaxis. On that list are some rare and dangerous consequences of antibiotics and other drugs that we'll get into a minute. But one of the scenarios that I see that we evaluate are people who they're on amoxicillin and then they'll have a rash a few days later. And they're always wondering if this is penicillin or amoxicillin allergy. And there's a separate problem called amoxicillin rash. For most people, it's going to be if they have mono. If you have mononucleosis and they think it's strep and they treat it with amoxicillin, a few days into the course of amoxicillin, you can get a rash. And it usually doesn't itch. It's not a hive. It's not the raised red itchy welt. It's a flat, non-itchy rash. And it's late in the course of amoxicillin. That is not an allergy. And there's some approaches that if you have that history, they still treat you with the next time with amoxicillin. But in children, that response is not as selective for mono. It can be from just about any virus. But the combination of amoxicillin and mononucleosis, that's the classic one. And so that is what I would be hoping for when I meet someone, that we're just dealing with amoxicillin rash as a child and it doesn't apply to a penicillin allergy. There are some rare and dangerous conditions, and so when I'm taking the history, if anyone has a history of blistering, then I won't test them. They should not be touched with penicillin because that's a very dangerous reaction. The other one is that they have a rash that spreads up into their lips and their mouth and into their eyes. And that is another dangerous reaction. So I'm always I'll show pictures of those, and I don't want to dwell on these pictures, but there they are anyway. And I'll show pictures like this to my patients, say, okay, you sure you didn't have this? Now, I'll just tell you that the majority of people don't remember at all. And many times we'll say, okay, let's get your mom on the phone. And they'll call their mom back in Virginia and we'll get more history. But I'm not kidding, the majority of people can't remember. Never knew. My mama told me, as one of my colleagues always says, Dr. Di Pasquale, titled a lecture, "My Mama Told Me I Was Allergic to Penicillin." But the further back in time it is, the less likely. And then the onset. So I'm interested in when did the onset of symptoms in conjunction with the dosing. So did it occur with the first dose? Did it occur within 6 hours of the first dose? Were there hives? Were the symptoms of anaphylaxis there? Those are the people who I would think twice, sometimes about testing, or I'm a little bit more concerned that that was a true allergy. If it were after the 10th day, not so concerning to be an allergic reaction. Well, how do we test? We do skin testing. We have the skin teach us if there's still an allergy there. And this is a time-honored type of test that's been around for decades. And we just take, and I think I can just go forward one more time. There we go. You see the little white rod there with the prongs? So there's several different apparatuses that we can use. This is one of them. And so it's a little plastic rod with prongs on the end with standardized testing material. And we just gently scratch it across the skin. It feels about like how a cat will push their claws down. It's not a shot like you see in the middle. And then we wait 20 minutes. And let me see if I can go backwards. Yes. So we test for we test for the house and the garage, if you will. The major determinant of penicillin, and then some of the more minor determinants. And separate from that, we also test for ampicillin and amoxicillin. And that pretty much covers it. And, you know, with our recent association with Mayo Clinic, they've been great. I contacted them and said, here's my protocol. Can you help me make sure that it's accurate? And so they helped me with my protocol. I appreciate our relationship with Mayo Clinic. There are blood tests, but they're very poor quality. So we've waited 15 minutes, and on your right you can see an example of positive skin tests. They're raised red, itchy welts, and the person on the other end of that arm, I promise you, is quite miserable right now in terms of the itching. And usually, truthfully, we don't get reactions that severe. But if there's a positive skin test on the forearm, I'll say, you're allergic. You are still allergic. We stop. We've tested all ages. We tested an 85-year-old woman whose allergy was before I was born, and I was born in 1954. So I thought, okay, this is going to be a slam dunk. She had a positive skin test. And I said, wow, you just broke all the rules. You're still allergic. We're not going to go forward with this. After 20 minutes, if this is negative with the prick skin testing, we'll take the same material and just sneak a little bit of it up on the upper arm. The arm is being numbed with a numbing cream, and we just put a little tiny bit under the skin, kind of like a TB skin test. And we wait 20 minutes. If this is positive, we stop. You're still allergic. So this is prick skin testing. This is intradermal skin testing. Skin testing here has been useful for medications, for foods, for inhaled allergies, for stinging insects, for latex. There's a lot of usefulness that you can just throw the net out as widely as you can to see what you get. There are limitations, but if you know your limitations with this, then you can get a lot of useful information out of it. Let's see. So if you are skin test negative, then the next step is that we feed people amoxicillin. And we wait an hour, and we follow their vital signs every 15 minutes. And pretty much everybody, if they get through that first hour without symptoms, then we're good. I haven't had anyone who's had a delayed reaction beyond an hour. There are some doctors that'll make people wait 2 hours, but the standard protocol across the nation is an hour. So that's how it works. Now, in 1980, I took the Hippocratic Oath, which says, don't hurt people. It doesn't say make them better, it just says don't hurt them. And so, of course, we take that very seriously. In my heart of hearts, I know that the information that we're getting from this is worth the risk for almost everyone. But we do talk about the safety, of course, when we do this testing. Across the nation, there's about a 1% risk of adverse reaction. That you get through skin testing, this is negative, and this is negative, and you feed them the antibiotic and they have a reaction. And we've had a few people who've had that happen. In almost all of them, it's been itching or a little bit of a rash. We've had one gentleman who had a significant rash with itching, and he turned out okay. We've only had one reaction where it was slightly worse than that. But we've not had to send anyone to the hospital or put an IV in or give people oxygen or anything like that. Now, we are pretty careful about who we choose to test. Little young ones, like a 2-year-old, if they've had a recent reaction, I wait a little bit. Because little ones, if they do have a reaction, it can be a little bit more severe, and they would not be able to tell you, Mama, tell Dr. Foote my throat's itching a little bit. They don't have that wherewithal. So we're pretty careful about little ones. The timing of the test is important too. I mean, if it's been 2 weeks or less, then all of your allergy cells in your skin, if they were firing off 2 weeks ago or less, they may not have any histamine in them left to give you a good reaction. So you have to wait a little while for those allergy cells to replenish themselves. There are people who've had such severe anaphylactic reactions that I just didn't think that it was safe to skin test them. So we try to be wise and conservative about who we choose, but most people we can help them. So what's been our experience at the clinic? Well, I have to thank the hospital staff and the medical staff in Fairbanks because we've gotten support from the community. And I'll just tell you, there are communities in Alaska that does not have the other doctors' support for doing this work, but we have had that. And over the past 4 years, we've treated 231 people, and 188 people had negative skin tests and passed their penicillin challenge and walked out of the clinic knowing that they were no longer or never were allergic to penicillin. We've had about 40 people who've had positive skin tests, and I think about 6 people who have failed the test, like I referred to a few minutes ago. And then in the past year, we've ramped up this program with pregnant women who are at the end of their pregnancy and they test positive for group E strep, and we just skin test them. We don't challenge them in the clinic for safety issues for the mother and the baby. And we have a protocol with the labor and delivery team over at FMH and with the obstetricians where they challenge them when they come in to have their baby. And so we've tested 9 people, and 6 women successfully passed their testing procedure, and 3 women had positive skin tests, and we didn't go forward with challenging them in the clinic. So that is the conclusion of my lecture. And again, I appreciate the invitation to talk about this. It's one of my favorite subjects. Thank you.